Get Reporting with me. I'm Dr. Matthew Leonardi. I'm here to teach you how to interpret ultrasound. We'll cover everything from the basics to advanced techniques. So whether you're a student, a healthcare professional, or just curious about ultrasounds, I hope you'll join me for the reporting ride. Hey everyone, it's Dr. Matthew Leonardi here for another episode of Get Reporting with me. Had a little bit of a break over the holidays. Welcome to 2024. Happy New Year, everyone. We'll start the year with a little bit of an easier case. This is a young patient who was sent to me for a second opinion for myometrial cysts. Now, myometrial cysts are cystic-like structures that exist within the myometrium, and generally, these are a direct feature of adenomyosis. So it is a very important diagnosis to make right. However, there are some things that can be sometimes confused for myometrial cysts, and I think that this case has demonstrated that, as you will soon see. So here we go. Let's begin. Image number 1 here is a transabdominal view. Transabdominal view of the uterus in transverse TRV. Image number 2, sagittal view of the uterus. Now, I'm already starting to look for these supposed myometrial cysts. And in this still image, I don't see any, but I see a cervix, I see an endometrium here, right ovary, left ovary. Moving on to the transvaginal views. Here we have a sagittal view of an anteverted uterus. And we can see here a cervix, and we can see an endometrium, and the endometrium thus far is seemingly quite thin. We are appreciating that there is a little bit of asymmetry between the anterior and the posterior myometria. And if I were to apply a tool to measure that, we would see the anterior is about 8.9 millimeters and the posterior is about 18.5. So this definitely meets the criteria for asymmetry. However, asymmetry is an indirect feature of adenomyosis as per the Musa group. So that alone should not give us a classification of adenomyosis. We should identify other features. And of course, we're looking for myometrial cysts in this case, as those were previously identified. In this still image, I'm not seeing any other features. Here we go, scanning through. This is going to be the money. Let's pause. Let's go back to the beginning. We have a right to left sweep here. And as I'm scanning through, I'm looking for myometrial cysts, subendometrial lines and buds. I'm looking for hypercoic islands. I'm looking for fan-shaped shadowing. I'm looking for irregularities or interruptions in the junctional zone, and I cannot see any. Specifically, this junctional zone looks very normal all the way around this nice thin endometrium. If we look specifically for myometrial cysts, I'm not seeing any, but what could they have confused those for? So I'll point to this area right here where you do see some anechoic cystic spaces, but those are blood vessels. These are classic vessels in the arcuate vessel region. And if you scan through them slowly, you can appreciate that these little anechoic spaces actually lead into one another. So those are vessels there and not myometrial cysts. So I'm not seeing any myometrial cysts here. And so far this thickening is persistent, but there's no clear reason for it, I don't think. Nah, I can't convince myself that there's anything there yet. Scanning through, we have some views of the cervix. The cervix is a place that can also confuse individuals as there are glands within the endocervical canal. And so sometimes we have little cystic spaces in that area, which can be called endometrial, or sometimes, if they're a little bit more peripheral, myometrial cysts. Those are just sometimes early Nabothean cysts. If they're on the smaller side, they can get a bit larger as well. Here's a transverse cervix view. And so we have this sweep here, which kind of converts from a sagittal to transverse view. Let's see what's next. So that's a nice sweep through transverse. If we start at the beginning, we can follow this up. And there is a little area here. That's a little cystic space. But that's about it. Just that space right there. Transverse measurement of the uterus, very normal, very small size uterus. And a thin endometrial stripe here. Nothing really to make of it. And then here we go. Our sonographer also identified that asymmetry, rightfully so. And we got about the same measurements. But even still, in this picture where they're identifying the asymmetry, there's no direct features identified. They throw on the color Doppler flow vascular patterns, again, rightfully so, and it's pretty normal. The concept of translesional vascularity has come up before. This is a MUSA feature that really should only be used in the context of some direct features that help differentiate from a more focal adenomyosis state versus diffuse, or an adenomyosis versus a fibroid state. In the absence of any other features, translesional vascularity becomes a lot less reliable, and so therefore I don't really apply that rule very often. Okay, moving on to the ovary. This is not really a case about ovaries. And you can see here we have an ovary in sagittal view with some follicles present. There's the iliac right there. We have a normal ovary on this right side with a normal volume. Nothing dramatic about it. Here's a nice sweep through the ovary. I always do a count if I have any subjective concern for polycystic ovarian morphology. And this ovary has a normal number of follicles. There's about maybe 6 or 7. The threshold of PCOM, according to the latest 2023 guidelines, is 20 or more follicles, not measuring more than 8 millimeters, or you can use volume of the ovary more than 10 milliliters if there are no corpus lutea, dominant follicles, or ovarian cystic lesions. Here's the left ovary, also kind of instantaneously appearing normal. Normal volume, again, normal follicles present. Scanning through it, coming backwards here. 1, 2, 3, 4, 5, 6, 7, about 7 or 8 follicles there as well. Very normal in appearance. All right, so just back to the uterus as we near to the end. And our sonographer is looking very carefully for myometrial cysts, also looking very carefully for other features of adenomyosis, in particular, some of those direct features, subendometrial buds and lines. And so we're looking at this region here, and this is looking very, very good, very normal. Taking a sweep of the posterior compartment. This is becoming more and more routine for me and my team as we scan many patients for endometriosis. And anytime there's fluid in the pouch, it's an opportunity to look for things that could be there. So this is not a patient who is particularly concerned about dysmenorrhea or other endometriosis symptoms. Nothing is jumping out at me here. Normal fluid, normal rectum here, some small bowel activity, and then getting to the psoas muscle just there. And that's our last image. So I'm gonna stop sharing that screen and then just conclude here. This case is a pretty typical case in some ways. Typical in that I've received a referral for something that has been identified, and we are actually changing the ultimate diagnosis in the end. We're not able to confirm what was previously identified, and we can reassure the patient that there is no evidence of direct features of adenomyosis. There's no myometrial cyst, there's no endometrial cysts. There are a few glands within the cervix, and those are normal. And there are, of course, blood vessels in the uterus, which are normal. So this is a very reassuring scan. There's no actual identifiable problems. It's really important to not only understand why you're scanning a patient that somebody else has scanned to either confirm or refute findings, but also the original reason. And sometimes that's made clear to us when we're doing second opinion scans, and sometimes it's not, because maybe the original scan was misled by the myometrial cysts in the diagnostic approach. If there was concerns for abnormal uterine bleeding or dysmenorrhea, again, this patient didn't really have any dysmenorrhea. And as it turns out, the original requisition was for urinary frequency. So those myometrial cysts were actually kind of an incidental finding, though in some ways adenomyosis could be an inflammatory condition that does irritate the bladder, and then it is a little bit relevant. but really it was more of an incidental finding of the uterus when they were looking for other pelvic reasons for urinary frequency. So we can actually reassure this patient, and hopefully she'll feel very positive about having a normal uterus. Now, this asymmetry is not enough for us to characterize adenomyosis at this time. Most likely, this was a transient contraction of the uterus of the posterior myometrium, and that's something that we see. I always recommend that we look at the uterus at the beginning and at the end if we are concerned for asymmetry, particularly in the absence of other features. And in this case, that contraction didn't let up, so it was pretty consistent through the entirety of the scan. We might consider, though in this case I've not done this, we might consider if we had some other equivocal findings or we had a bit more of a clinical sense of adenomyosis, that maybe we could look again at this uterus in a time point down the track, like 3 months or 6 months or even a year, as adenomyosis is probably not a very fast changing disease. I haven't made that recommendation, but of course it is up to the referring provider to continue to follow the patient and make sure that their investigations continue to be appropriate as the symptoms may change with time. So normal scan in this case, from our perspective, really reassuring, and that's really important to be able to provide. Many times the scan's abnormal, but finding normal results is also really important and reassuring. See you next time. Thanks again.